Thanks for inviting me. Okay, so this arose because last spring I was asked to speak at a health research town hall titled Social Accountability in Healthcare. Even if the title was Social Accountability in Healthcare, the focus was on medicine. And the discussion that I had with the other two presenters prior to as we were getting ready for the presentation, was really focused on the School of Medicine, their social accountability framework, and how it was implemented as part of the curriculum. And here it is here. And it's quite nice, actually. And they have a Center for Social Accountability. So everything was given through a medical lens and not about nursing. But I think I was able to demonstrate social accountability has always been a foundation of nursing and how closely it's aligned and similar to social justice. So to start, I examined the framework for the Center for Social Accountability and found that it is well aligned with nursing. Medical schools in Canada identified social accountability in 1995, according to Emily's discussion right now. But in fact, social accountability has been part of the DNA of nursing from the beginning. Here's Florence Nightingale, and she's become a bit of a, I don't know, I don't want to say it, but a bit of a joke in some ways. But you know what? She moved nursing from a domestic service to a profession in the 1800s. And one of the foundations was advocacy, where she promoted practical strategies to address health inequities and injustices. And as a woman in the Victorian age, she really had many limitations, but used her rank and position to leverage and enact many reforms. She was really skilled and very well educated. She was a statistician, and she demonstrated that the poor water quality in the battle hospitals was killing more men than their wounds in the Crimean War. So she wrote to government officials and stakeholders to call for better conditions for the wounded soldiers. She also fought for reforms at a hospital for women, and she fought for care for those with mental illness who the healthcare system was neglecting at the time. So that was the 1800s. And if we move forward 150 years, nursing as a profession has continued to demonstrate social accountability. The Canadian Nurses Association defines social justice as a tenet of nursing. It's defined as a fair distribution of resources and responsibilities among members of a population. The definition identifies that nurses and healthcare providers must focus on the root causes of disparities and what can be done to eliminate them, much in alignment with social accountability. So in collaboration or in alignment with the College of Family Physicians of Canada, the Canadian Nurses Association, they both agree that social justice is the responsibility of all, including healthcare providers. And achieving social justice means addressing issues beyond formal healthcare system that have a direct impact on health and wellness, such as what's listed here: food insecurity, adequate housing, adequate income. And I think we could have filled in these blanks easily. The undergraduate curriculum in nursing and the nurse practitioner program at Laurentian University aren't specifically founded on a social accountability framework, but the concept permeates every course, all clinical environments, and it's also demonstrated in practice. So I speak now as a nurse practitioner because I've been an NP for 23 years and have taught mostly in the nurse practitioner program for more than a decade. One common characteristic of nurse practitioners in all the literature across Canada, and I would dare to say across the world, is that we work for the most part with vulnerable people in our society. The Sudbury District Nurse Practitioner Clinic's expansion to the downtown Sudbury area to care for homeless, addicted, and mentally ill patients is one example. So in the social accountability framework, it speaks to education and practice, which we've also touched on, but also research. My profile at the university says that my research is focused on NP education, practice, and policy, but that's only a small part of it. I've supervised numerous master's and PhD students who studied a wide variety of topics using a variety of methodologies. Each student is expected to identify a philosophical or conceptual framework that guides their research. And inevitably, the students strongly identify with a social accountability lens. For example, one student of mine, a nurse and psychotherapist, studied the quality of life of people with borderline personality disorder. One part of the study was to examine the factors associated with frequent emergency department visits for people with BPD. Not surprisingly, more visits correlated with less education, less family and social support, unemployment, involvement with justice system, and more. We found that the only way to gain real insight into the challenges faced by this population was to focus on the social determinants of health. The discussion arising spoke to the gaps in social services that would support these patients and move them toward a better quality of life. Okay, I've learned many things about research, and you're going to take some research courses. And what you may end up thinking is that quantitative research and statistical analysis are objective. In fact, researchers demonstrate the lens in which they view the world through the research question, the data items that are collected, the items that are analyzed, and most importantly, the interpretation of the findings. The perceptions that inform the interpretation of a study findings are important because they add richness and depth to a research study and point to many directions for further investigation. However, this takes me to the next area of the social accountability framework, where community advocacy is identified. This area is arguably the most important because it's where action and change arise from the framework, but also the most difficult to address because it's most often about policy. Governments at all levels create policy and move resources to support programs arising from them. The entity that interprets the data and holds the purse strings has the power. We're told that evidence drives policy, but I'm not so sure about that. It would be curious to know how many decisions about COVID-19 in Ontario, for example, arose from research evidence. One thing seems clear, and that is that the lens from which governments view the world informs their interpretation of evidence and determines the priorities of the projects that are supported. And here's a story from my practice that helps to demonstrate the point. I worked at Shigok-McQuay Health Centre, an Indigenous health access centre in Sudbury, as a nurse practitioner from 2004 and 2012. During this time, people in the community of Kasheshawan were evacuated to various communities across Ontario twice because of flooding. We provided healthcare to those who were relocated to Sudbury. After assessing numerous people with skin conditions, it became apparent that not only was the water undrinkable, but that it was likely contributing to illness, as well as driving them from their homes and disrupting their lives. That was almost 20 years ago. Just before I presented this in the spring of 2022, I read a tweet by Charlie Angus, an MP from the North, who said that the situation in Kasheshawan was dire and that evacuation was necessary. So even with experience and evidence for decades, this has not been made a priority. I'm sure that through your practice and research, you can identify numerous issues where health is directly impacted by social problems. The evidence is available and clearly points to possible solutions, but where there is no political will to address them. Decisions about policy are based on a number of factors. The worldview of elected officials and bureaucrats can mean very, very different paths and priorities. Take, for example, New Zealand. They put out what they call a well-being budget. So in this budget, they have 4 capitals: human capital, natural capital, social capital, financial and physical capital. So their goal is that the capitals underpin well-being in the medium to long term, as well as supporting it in the present. In contrast, these are the headings for the province of Ontario's most recent budget: rebuilding Ontario's economy, working for workers, building highways and key infrastructure, keeping costs down, and a plan to stay open. The different sections demonstrate the priorities of the government and inform very different approaches to policy. For example, it's hard to ignore the evidence that smoking and vaping causes cancer, cardiac disease, and more. In Canada and Ontario, a strategy to stop smoking and vaping is to tax products. Only through enormous efforts, largely led by public health, part of the strategy to stop smoking was to restrict where smoking and vaping can take place. In contrast, New Zealand has a new law that sees the age at which it is legal to smoke rise each year until it will be illegal for anyone to smoke. So it's not to say that one approach is right or wrong. After all, these are both democratically elected governments. But it's clear there's a different lens underpinning each of these approaches. The headings or frameworks used for the budgets point to very different, tightly held beliefs. Often people can't comprehend that things can be viewed differently, making it incredibly difficult to create change. While we lobbied to open the first nurse practitioner-led clinic, my colleague and I, Marilyn Butcher, faced incredible barriers. And one of the most significant was that many people couldn't comprehend that there could be a clinic where nurse practitioners were the primary care providers and not physicians. Yet we persevered because at the time, about 20% of Sudbury's population was unattached or didn't belong to a family practice. Okay, circling back to our role as now educators, clinicians, and researchers. Again, the hardest part by far is using our experience and evidence for change. Living social accountability means that we have an obligation to advocate for positive social change. However, knowing the barriers, we have to be strategic. Research findings and issues need to be made known beyond the professional and academic walls. So with an academic in a master's program, for example, I think we have to look beyond conference presentation and publishing papers. We need to take our message to a far wider audience. We need to seek ways to leverage our own rank and status to speak for those who don't have a voice. But there are many voices, often with messages that are in conflict with our own. So what can we do among all the voices of those who are fighting against social change and those who are pushing for the status quo? One idea is to use social tools available. Social media, Facebook, Twitter, blogs, podcasts. Now, if you're overwhelmed with this idea, I understand, because as educators, clinicians, researchers, etc., lobbying and social media advocacy isn't really what we signed up for. However, if the last few years have taught us anything, it's the ubiquitous nature of these tools and the power of them. So for me, what I see that advocacy for social change as vitally important, including the development of strategies that meet people where they are as a way to shift beliefs and mindsets of those who can put resources toward positive social change. So as I wrap up, social accountability is essential in healthcare education and in healthcare research and practice. But the key that binds all these together and the most difficult to achieve is advocacy. And I've dabbled in a few new things for me on and off, and the ubiquitous evolution is a podcast. And just to give you an example, I've interviewed some fascinating people. One was a podcast a few months ago with a woman, a nurse practitioner who works with trans people and provides primary healthcare for trans populations. So it was a really fascinating discussion. I've just finished an interview and have to get it ready and post about a nurse practitioner who implements MAID, that's medical assistance for dying. And you know, in every discussion we have, there is some element of advocacy that needs to happen and that they're implementing themselves. So I encourage you to think about tapping into some of these if you're interested.